My name is Francesca, and I'm very glad to welcome you all to this place. Can anyone not hear me? So right at the back, you're hearing me. I'm not going to use a microphone, if that's okay. I started off my life, in fact, I think my membership number for the Clinician Society is 208, which goes to show you that I've been a member of the society for a very long time. And I started off my research career in 2000 when I joined the clinical HIV research unit. It was in those terrible dark days before we had antiretroviral therapy. We were doing clinical trials, and the field has gone absolutely crazy since then. Now we have 1.8 million South Africans on various estimates on antiretroviral therapy, so we've done quite well. But what I've noticed, and I'm sure I'm not the only person in the room, and one of the things that I want to change in the society is we need to be focusing on the other big problem in our country, which is, as we all know, TB. I am proudly South African. And in terms of incidence rate, there's only one country that beats us in TB. Anybody got any ideas on who beats us in TB as an incidence rate? Sorry? No, that's absolute numbers. A big piece of a very big pie, very small slice, lots of TB patients in India. Swaziland has more patients, more incident cases than we do. Now, there is quite a difference between us and Swaziland, and I think I just need to say the reed dance, and most of you know what we mean. There's a whole lot of difference. So it's of great shame that we are so high in the list. And roughly 1% of South Africans get TB every year. So in this room, one of us is going to get, no, I've revised that. 3.5 of us are going to get TB in this room because we are healthcare workers. Please, guys, observe good infection control. What I'm going to talk about, though, today is why I think the TB program has failed. I am not a microbiologist or an epidemiologist, so if there are flaws in my argument, please ignore them or come and talk to me quietly afterwards. But I'm looking at my walk through. When I was an intern, we used to have the odd case of TB mixed in amongst things like myocardial infarctions and the odd little bit community-acquired pneumonias. Now, TB has to go through our mind with every single patient that we see. Something has changed, and why do I think, Francesca, has this program failed? The first thing I want to say is I attended the conference, the lung conference last year, and I met this woman who's a woman after my own heart. And this is what she said. In this hour while I'm talking, 160 people will die in the world from TB, of which just over a third will be women. We've got to do something to stop this. This is a disgrace. Every minute I speak, a woman will die of TB. So, and we failed in the program. Oops, there we go. Okay, this is a slide that I took from an article written in 1994 about the projections of what would happen to TB in Western Europe. So we can see what's happened. Which one is the bottom one? The bottom one? Yeah. No. Oops, oops. No, I want the pointer. Oh, the middle one. The middle one. Okay, there we go. So we can see TB was at its highest rate. This is the number of people that died from TB. So it was very high in Western Europe around the beginning of the 18th century. It started to go down, and this was before the advent of TB treatment. In fact, TB treatment was invented around here. There was a little blip here. This corresponds to the World Wars. And if we just were to follow this down, we would now say that there should be no deaths from TB at all in Western Europe. And in fact, there are over 10,000 cases in Britain alone, and there are about 1,000 deaths in Britain from TB. So TB we haven't sorted out the problem, and let's try and work out the reasons why. Have we sorted out the problem in South Africa? So we've talked about Europe. We haven't sorted it out there, but the situation is much worse. And this is slightly out of focus. I think it's because I tried to enlarge it too much. But we all know the situation. What has happened is HIV incidence has increased, and alongside it, so has TB incidence increased. Okay, we can all go home, because this is what everyone tells us is the reason why we failed. Because HIV came along and it messed up the program, and that's it. And first of all, HIV was first documented around the early 80s. So we've had it a long time. We should have been able to respond to this in some way. And second of all, I'd like to argue that the problem is more profound than the appearance of a new epidemic in the form of an immunocompromised disease. This is taken from the same article, the article in the American Chest Journal, whose name I've forgotten, saying what would happen if we just projected forward based on the figures if we had in Africa a low HIV incidence. And if we have a look at that, darn, I'm going to tell you all my secrets before I get any further. If we have a lower HIV incidence, which we don't, then we would have an infection rate of around 130-40. If we projected forward using the same figures, this doesn't even come close to the kind of incidence rate that we have in South Africa. We're looking at 974 cases per 100,000. So that 300 at the top of the confidence intervals is not even close. So something has gone even wronger, if I can use such a word, than HIV coming along. And what are the more difficult answers to that? I'd like to argue that there are some policy reasons, and I will pick them out, remembering that I'm not an epidemiologist. I'm going to look at some reasons why I think that our lag time in diagnostics has brought us down quite a bit. We stopped thinking about treatment in about 1976. And I'm going to talk about the changes that is happening there, and then what kind of research answers are we looking for? And then I'm going to come up with a magic bullet, which I hope when I'm president will come to pass. Okay. Where I'd like to start is, we've got a fundamental problem, I think, with the way that we speak about TB. Control. We talk about TB control. If we talked about HIV control, I can tell you, Mark Hay would bitch slap me. That's unacceptable. We talk about prevention. But here, control is the word that we use. A suspect. If I see someone running down the street with something under his arm, he is a suspect. If I think someone has got TB, they're a suspect. Both of them are somebody who we think might be guilty of an illegal or dishonest or unpleasant act without certain proof. And that is what we call people who are coughing. You are a TB suspect. You are a criminal until proved otherwise. That is unacceptable terms. This afternoon, I signed the bond documents for my new house. And I was told what would happen to me if I defaulted. So there are consequences. I have an obligation to pay my bond. If I don't pay my bond and I default, and that's what we call people who don't take their TB treatment properly. We're taking the responsibility completely away from us and giving it all to them and saying, you didn't do what you were supposed to do. And I'd like to contrast with that with the language we use in HIV. We talk about adherence. Adherence is a team approach, where I take my knowledge that I have gained over the short 25 years that I've walked this earth, and I impart it to, sure, you're a sleepy lot, and I impart it to people who I treat. I'm not particularly clever, but I do know quite a lot about HIV, and I can take that knowledge and talk to people about it who have PhDs, and I can talk to people who don't have any education at all. And it's a team effort. The person who's sitting in front of me is HIV infected, and I want to teach them how to manage their condition. So it's a partnership. We talk about loss to follow-up because we in the HIV world accept that if people are not adherent to their therapy, we are partly to blame. And what can we do to improve it? Is it to listen to our patients better, to get medicines with better side effect profiles, open our clinics on, God forbid, a Saturday and Sunday? Things, we talk about care, treatment and support, not control. And prevention. We're not the bosses. We are in a team with the people who are potentially HIV infected or who are HIV infected. So we've got to revise the language that we use right from the very top. Then we're going to talk about this policy called DOTS. DOTS has various aspects to it, and I'm not going to go through all of them. I only want to talk about one in particular, and it's one I particularly hate, and that is directly observed therapy. Okay. I think that this is a paternalistic and ridiculous form of therapy. I work at CISWE, where we treat patients for drug-resistant TB. And I saw a young man who, for the first time, and I said, is this the first time you've had TB? And he says, no, it's the third. The first 2 times I felt better after about 2 months, and I stopped taking my medicines. And I said, well, didn't they tell you? And he said, no one told me that I would end up being isolated in this hospital, having to have an injection in my backside every day for a minimum of 6 months. And actually, he couldn't really hear me because he'd gone deaf from his aminoglycosides. No one had warned him of the consequences of not finishing his TB treatment. And that, I think, is negligence. We need to tell people what the consequences are of not finishing your treatment. So I had a look around to see if anyone else agreed with me. And in this very large Cochrane review of all the studies looking at whether directly observed therapy works or not, the answer is no. They had a look at 11 trials. You know how they select all the trials about endpoints and the ways that they did it. I'm not going into that because that starts to get a bit boring. But they looked at 11 trials with over 5,500 people. And they found that if you did DOT as opposed to self-administration, there was no statistically significant increase in the relative risk of cure. So we're spending all this time and money watching people swallowing their medicines. But what we really want to do is to make people better. And we're not doing that with DOT. And yet it is written in, I think we call it the WHO says it works, and it works. And there's no evidence to show that DOT works. There is small evidence to show that if there's home-supported DOTs, it helps. But really, you can see that the difference is not worth the kind of money that we are spending on doing DOTs. So the conclusion of this is, and they put all the trials up, you can see some of the trials even border on being hazardous. That if you are instituting DOTs, you might be doing harm to your patients as opposed to good. I think I would find it offensive that people would think I was so stupid I couldn't manage to take my medicines on my own. And in fact, that was the conclusion, that there is no evidence that directly observed, that watching people taking their medicines improves the rate of cure. And that is the point of treating TB. This is a quote from a patient in Pakistan, and it says, it doesn't make sense as to why a grown-up person should be given medicines by someone else. I feel very awkward. And I try to take my medicines by myself. And I think that that's the kind of thing that we need in TB. In HIV, we have adherence counseling. We sit and explain to our patients what side effects to look out for. Big breasts, for example, as we all know. And we warn them of the consequences of not taking their treatment properly. We talk about prevention and the need to take their medicine so that they don't infect the people that they love dearly. But we don't do that in TB. In fact, a lot of time we forget to tell our patients that they will start to wee OROS, which is quite an alarming thing if you don't know it's going to happen to you. Then the WHO and the Stop TB Partnership endorsed 2 targets. The first one is that we need to detect at least 70% of the new smear-positive cases. And in addition to that, we need to cure at least 85. And there is, I think, one province in this country that actually reaches 85. And I'm not exactly sure why we accept 85%. I expect 100% of my patients to have an undetectable viral load. I'm not sure about you guys. I expect them all to be taking their medicines. And if they don't, I'm upset. And I try and assist my patients to find ways to take their medicines properly. So where did this 85% rule come from? It came from a renowned and I think well-intentioned man called Carl, and I hope I'm saying it right, Stiblo. I don't know if that's right or wrong. But what he did is he worked out that if you had 50 sputum smear positive cases in a population of 100,000, then you will have an annual risk of infection or pressure of infection of 1%. But in work done by Robin Wood and Linda Gale Becker, in Masipumalele, the rate goes almost up to 4 or 5%. So what they did is that they did skin tests on children and then they repeated them for a couple of years. And children acquire TB at a rate of about 4%. So 4% of the kids get TB every year. There's never been the amount of TB that there is now, except for maybe somewhere around the Middle Ages or a little bit after that. And yet we're still sticking to the same rules. We need to change the rules. We need to not only look for 85%, we need to find more than 70% of the cases. They have ways that they predict how many cases we should be seeing, but 70% is not enough. We need to be finding quite a lot more than them. Then other dogmas that were written into our TB Bible, as it were, is that you acquire your TB as a child, and then something happens to you and you break down to active TB, and we all know the 10% per year or what. But in actual fact, that dogma is incorrect with the pressure of infection that we have in South Africa at the current time. When they've done fingerprinting by some magical method, which I clearly do not understand, they found that the vast majority of cases of TB are cases of TB from the currently circulating strains, which means that what people are getting is what's going around not 5, 10, or 20 years ago, but what's going around right now. So it's the debate between reinfection and reactivation. And in fact, there's far more reinfection than we ever imagined. I'm sure all of us have seen patients that have had TB more than once. And sometimes when they were HIV infected and sometimes when they weren't. If you have TB in 2000 and you have TB in 2012, you might not have been HIV infected when you got it for the first time. In addition, we talk about household contact screening, but a lot of work has gone to show that perhaps the places where people are catching TB is not at home, not exclusively at home. Of course, if you've got a 5-year-old child who sleeps in your room and you've got open cavitating TB, the chances are that the kid's going to get it. But in actual fact, with the pressure infection that we are seeing now, it's not happening in the home. Where is it happening? And I think the fact that we do not know where people are actually acquiring their TB is not good. Certainly people are acquiring TB under our own watch, in our own hospitals. And I've had cases that are undeniably hospital-acquired TB. Any healthcare worker who gets TB, the chances are very high it's hospital-acquired. People are probably acquiring their TB in public gatherings. And also, who likes to drive with the car window open? Not me, because, you know, the locks, the hair. And you can imagine being stuck in the same taxi for an hour on a cold winter's night, on a cold winter's morning or evening. If someone in there's got TB, by the time you leave, all of you are going to have TB. And 50% of recurrent disease occurs in endemic settings is not reactivation disease. It's in fact reinfection. It's people getting it again. So we've got to re-look at the dogma, the things that we were told at medical student that were, you know, just after Moses wrote the 10 Commandments, he wrote this. It's not actually true. In terms of basic epidemiology, and I won't go on too long at this because very soon I will be bussed as not knowing very much. But if we have a look at the basic reproductive rate, if it is above 1, then an infection can take hold in community. If it is below 1, it can't. And there are various things that will determine how likely it is to be above 1. The first thing is the duration of infectiousness, and then the likelihood of transmission. Of course, the likelihood of transmission is improved by HIV being around. If you are immunosuppressed, you're more likely to catch HIV and TB, and if you don't believe me, then I think you probably are not at the correct meeting. That garlic and potatoes is just around the corner. And then the duration of infection. So that speaks from the time that you acquire your infection and being infectious to the time that you actually start swallowing appropriate medication. And I think that that's one of the biggest faults of our TB program, is that when we find the people finally, they've already been out there and infecting members of their community and their family for not a couple of days, but for months. Because we use this method, well, until very recently, we used this method. And if I spoke to the HIV doctors in this room, which you all are, and said, guys, you know how we're going to diagnose HIV is we're going to look down a microscope and see if we can see it, you would laugh me out of the room. Because A, it's dangerous, and B, it seems a little bit old and clunky. And yet this is the method that we have based our TB diagnostics on since even before I was born. In fact, twice my age and some more. Because the original stain for acid-fast bacilli was developed by Robert Koch 111 years ago. So what is going on here? How did we fall asleep? When we look down a microscope, we can see acid-fast bacilli, but we don't know whether they're alive or dead, and we don't know whether they're TB or not. There could be mycobacterium other than tuberculosis, and those are not necessarily pathogenic. So the gold standard for diagnosing TB in the main is to culture it. And culture can find 10 or higher colony-forming units per mil of sputum. We can speciate with it, so we know whether if they grow, they're alive. If they don't, they're dead. We can speciate, so we can say this is tuberculosis. And the traditional forms of culture were used. The first one was an egg-based, the LJ slopes. Then we found that we could culture it a little bit faster if we used a liquid medium. And now we have a more automated method of being able to find the diagnosis of TB a little bit sooner. But we are still talking about a lead time of up to 4 to 6 weeks before we can say this is definitely TB. And for those of us who have a skinny person sitting in front of us with a CD4 count of 23, I don't know about you, but we cannot wait. Because if I'm going to wait for that investigation, I will be attending more funerals than I will be writing out prescriptions for antiretroviral therapy. So then we decided, let's apply our minds and come up with molecular testing. And the first kind of test that was really promulgated for this was a line probe assay made by Hain Life Sciences. The Hain Life Sciences probe can do two things. The first one is it can speciate, say yes or no to being tuberculosis, and then can also tell us whether the patient has resistant or sensitive TB. I was reading up about the development of this, or the understanding of this RPOB gene. In fact, it was discovered around the mid to early 70s. And then it took until the late noughties, or whatever we call this period of time, for it to be incorporated into a commercially available test to diagnose drug-resistant TB. Guys, we fell asleep for 30 years. What were we doing in the time that we forgot, that we didn't remember about this particular gene mutation? RPOB is quite a simple gene that confers resistance. If it is, the mutation confers resistance to rifampicin. The limitation of a line probe assay is it must be done on someone who has a smear positive specimen. Now, again, the clinicians in the room, have you ever seen someone with a normalish chest x-ray and you tell them to cough in a bottle, and then 4 days later, then it comes back smear negative. You start them on the antiretroviral therapy, and then they get an immune reconstitution syndrome roughly the same time as you culture TB from their sputum. So culture negative. This is not uncommon, and depending on the rate of, or depending on the person's CD4 count, it's inversely proportional to the incidence of a culture negative, of smear negative culture positive disease. And this is what the tests look like. They can be read in strips, and all I can say is it looks like these people were pregnant with quadruplets, or perhaps a lot more. And the next iteration of the line probe assay is we're starting to look at whether or not we can detect XDR or pre-XDR. In the Tugela Ferry outbreak, the majority of people acquired their XDR TB in the hospital itself. And the reason, and were not put onto appropriate therapy if such a thing exists. I don't think it does at this stage. But we need to try and at least separate out the XDR patients so that they don't infect other patients who do not have full XDR yet. Then along came Father Christmas. And Father Christmas brought us the best invention for the diagnosis of TB easily within my lifetime. And that is the Gene Expert machine. It's a very simple test, a moderately expensive test, but it does have the advantage of a rapid turnaround time, and it can tell us whether or not our patient is sensitive or resistant to rifampicin. And I'm not getting into the debate about which probes we use and how sensitive they are, but we can pretty much diagnose drug-sensitive TB within a 2-hour time frame, and usually a 1 or 2 day turnaround time to starting our patients on medicines. The test is very simple to do, and our department, the head of the Department of Health, the Honourable Aaron Motswaledi, has chosen to use this as our diagnostic method, and I think it is a very brave and very needed move. It's a simple test. It does not have to be run in a BSL lab. Very quick turnaround time, and even a doffy like me can manage it. But here is the rather sad thing about it. 4 years before this gentleman, Robert Koch, found the stain for TB, he actually discovered the causative organism for anthrax. Now, why have I put the two together? Because in fact, the expert technology was originally developed at the time when there was bioterrorism threats in the States, and people were getting envelopes of whitish powder and they wanted to know whether it was anthrax or not. So we've come a full circle. Robert Koch did it twice before, and we've had to repeat it almost a century later to improve our diagnostics of TB. So how's it going in the country in general? And I think that this is a real testament to the National Health Laboratory Services in the way that we've rolled this out. The figures are absolutely staggering. At the moment, and this is the report that was written in April, so it's probably a wee bit behind, but not too much. You can see where all the machines are based. So quite a few around centres, quite a few in the areas where they're most needed. And these are the number of tests that have been run, more than anywhere else in the world. So far on our machines, we have run, I'm just taking claim for stuff that's really not mine, but I'm very proud of it anyway. Over 350,000 tests have been run on the GeneXpert machine in this country. Of interest is MTB detected, so we don't like using the word suspects, but we found that our detection rate is somewhere in the order of 16 to 17%. So when we suspect it, we're right almost 1 in 5 times. And in addition to that, if we have a look at the rate of resistance, we can see that our resistance rate is somewhere in the order of 7%, which is a lot higher than we estimated. And I think that when we find TB sooner, and the point of finding TB sooner is to stop people spreading it and to stop people dying. When we find it sooner, we're going to find far more resistance. I work at CSWA, and for some reason that I don't understand, anyone who is diagnosed with drug-resistant TB in this province, their name is written down in the register, and then they go and find them. And the city of Joburg, for example, is very good at finding people who've got MDR TB. But if they don't find them, you can usually, then you'll see as they start to fill in the register why they don't find them. You know, died 3 days ago, died 3 days ago. If we're finding patients sooner, we can treat them better and prevent them from dying. Okay, so now I've talked about the lag time in finding it, and hopefully we're going to shorten that lag time. Most definitely we're going to shorten the lag time for diagnosis of drug-resistant TB, and I'm pretty confident we'll do the same for drug-sensitive TB. But now let's talk about the treatment options. The first randomized controlled trial ever was done in 1946 when they randomly assigned people to get streptomycin versus nothing at all, because at that stage there was nothing. In the British MRC TB research unit, they conducted the trials and they found that streptomycin worked, but after about 5 years people died at the same rate as before, because all we did was push back the process, and people died then of streptomycin-resistant TB. Then the second trial came along when we combined PAS, which is still on the market and still being used, with streptomycin, and we found that that protected against streptomycin resistance. 1952, along came INH. Then thiacetazone was introduced in 1955. We had a look at the trials of various combinations and found that the best by far was streptomycin, INH, and rifampicin. Then pyrazinamide hit the market in the 1950s. That was developed by Cornell University, and rifampicin was found very shortly thereafter. In kind of a collaborative effort of Pasteur, the Pasteur Institute. So I won't go through all the trials because that starts to get a bit boring, but basically, to cut a long story short, in around the mid-70s, short course TB treatment was invented. So that's 6 months of TB treatment, 2 months of 4 drugs and 4 months of 2 drugs. And it was found that it was very efficacious. Drugs were co-formulated. In 1948, the TB research unit of the British MRC opened, and around 1986, it essentially closed because we thought we had it. In my career, and I qualified in 1988, this has been the only change in the treatment of TB, and that is co-formulation. That instead of giving our patients a handful of medicines, we now give them 3 or 4 or 5 purple tablets, depending on their weight and what formulation. That's all that's changed. And considering we haven't got the infection under control, I think we need to revisit this. So then what about for we've talked about drug-sensitive TB. What about drug-resistant TB? You know, the entire thinking that surrounds the treatment of drug-resistant TB is not based on randomized controlled trials. When I mention to people that I work with drug-sensitive TB, I see them visibly moving a little bit backwards in case somehow these germs have stuck to me and got them, because there's a lot of fear around drug-resistant TB. And so there should be, by the way, because it is a dreadful disease. And the medicines we use are absolutely atrocious. But until very recently, there was not one single randomized controlled trial for the treatment of drug-resistant TB. The stuff that we use, we do almost entirely based on expert opinion. And expert opinion is frequently driven by fear. The treatment regimens are long. The minimum time of, if you are, in our current regimen, both ours and the WHO's, if you are diagnosed with drug-resistant TB, you are committed to a minimum of 18 months of dreadful treatment and at least 6 months of injections in your bottom. And as I've said often, I have the size of bottom that could probably take, yes, thank you, that could probably take an injection every day for 6 months. But many of my patients have a BMI below 18.5 when they are admitted, and yet we still have to inject their poor bums every day. The side effect profile of drug-resistant TB is shocking. It's horrendous. 15% of the patients who are admitted to my hospital leave the hospital profoundly deaf, and that is a significant disability. Not only, and the worst of it is that it seems to affect the children worse than it affects the adults. And you can imagine a child losing its hearing when it's about 3. This is not a good situation. In addition to that, if you don't go deaf, you go crazy. And I'm not talking about, like me, a little bit odd. I'm talking about fully crazy. And we've had, since I've worked at CESWAR, 1 suicide. We've had serious suicide attempts. And people going, excuse the medical term, completely doolally. Almost no research has been done on how we can combine these drugs with antiretroviral therapy. I'm sure when I say patients going psychotic, you're all starting to think of efavirenz. And yet there's almost no work on combining these drugs and antiretroviral therapy. And in this province, 80% of our patients with MDR are also co-infected with HIV. So what are we going to do about this treatment stuff? Does anyone know how the dose of rifampicin was chosen? Cost. It was not chosen on whether it was the best dose in terms of toxicity or efficacy, area under the curve or MRC. It was based entirely on the cost of the drug. So we've stuck with this, with the value, but they are now looking at perhaps if we push the dose up to as high as 1.8 grams, and I know all of you are clutching your livers and hoping that they will stay in place. But it seems that even at these particularly high levels, rifampicin is not a particularly toxic dose, particularly toxic drug. And there's huge amounts of variation in the way that individuals metabolize rifampicin. So perhaps we are doing our TB program a lot more harm by underdosing people with an already too low dose if they metabolize their drugs quite fast. In terms of trials, we've had to come up with methods to decide whether or not TB treatment is working, because normally it is relapse-free, 27 months relapse-free. And that's quite a long time in the general world. So we've come up with new methods of trying to diagnose response to treatment a little bit faster. We can use early bactericidal activity, but in this case, the high-risk study, they've in fact using serial sputum colony counting. Another one that looked really promising was rifapentine. Rifapentine's got a far longer half-life, and they hopefully would need to be given, would have a better efficacy, but in fact, it's a little bit of a damp squid at this stage. PZA is the drug that probably is responsible for a lot of liver toxicity, and we can't really push up the dose much higher. When they've done studies looking at it, they found a very high incidence of hepatotoxicity. So then, it's only in the last probably 8 to 10 years that people have started really seriously thinking about whether or not we should get better medicines for TB treatment. The two drugs that are the closest to registration are bedaquiline or TMC-207, and the other one is an OPC or the Otsuka drug. If we have a look at the results from the studies, this is a study that I was involved in, where we combined TMC-207 or bedaquiline on a standard optimized background regimen. So what they would do is we screened our patients, then they were given open label optimized background regimen plus TMC for 24 weeks, and then were given optimized background regimen only. And then we followed them for a long period of time. We are almost done with this trial. We've got about 2 more months left, but the relapse rate is very low. So if we have a look at the overall time to sputum culture conversion, the vast majority of patients have converted their culture by 8 weeks. And that's a lot faster than normal. And of course, not only are the patients getting better faster, they're infectious for a lot shorter. But then if we split out the results according to how resistant the patients are, the yellow one is just straight MDR. So that's patients who are resistant only to INH and rifampicin. And you can see that at the end of 24 weeks, almost 90% of patients have sputum culture converted. And in terms of XDR, which is the red line at the top, 56.6% have responded if we add TMC to the regimen, which is far higher than anything that we've ever seen before. Pre-XDR is the one in between the two, which is resistant to either the quinolone or the injectable, and it's almost closer to the response rate of people with just MDR. If we look at the other drug, which is Delamanid, that one, it's the Otsuka drug. What they did is that they randomized patients to different levels of the TB treatment on the background of standard optimized background regimen. And if we have a look at the results, again, there was statistically significantly an increase in how quickly the patients converted their cultures if they had this drug added to them. So we've got two new candidates. But what about the old ones? These are the drugs that we now have for the treatment of TB. I've taken out the first-line drugs, but these are the second-line drugs. And the two drugs that are in a lot of favor at the moment in terms of combining with other TB medicines are clofazimine, which is an anti-leprosy drug and seems to work particularly well in synergism with the TMC-207, and anezolid, which is a very expensive antibiotic, seems to have quite a lot of action against TB. And unto that end, a new formulation or a new way of delivering the medicines is under development. So in conclusion, guess which is my favorite sport? Can't make up my mind, and I'm still a Lance Klusener fan. In conclusion, we need something to be completely differently done in our TB program. And I'm now speaking at the thoughts of Francesca and the way that I see the way forward if we are going to come up with game changes. The first one is we need to dump directly observed therapy and change it for proper adherence counselling. We need to continue the very ambitious rollout of the new diagnostics so that we can diagnose cases a lot sooner. And we need to do research into shorter and better regimens. Finally, I believe that in 5 years' time or 10 years' time, we will no longer be using any of the drugs that we're currently using, but we will have a completely new and shorter regimen that will treat all types of TB. And I'm prepared to put my head on a block as to the candidate drugs. I might well be wrong, but at least I've given it some thought. I think that we will combine TMC with PZA, clofazimine, the Otsuka drug, and the new linezolid, the PNU drug. And I think it will be a completely new regimen that we can then hand out with a far better side effect profile than anything that we currently have. Thank you.